And colistin definitely 100%. And even for others also, meropenem was sensitivity was good in most of them. Okay. Apart from that, amikacin was good. So based on this data, we kept meropenem, amikacin. See, polymyxins should never be given as empirical therapy. Colistin is never an empirical drug. You can never start, because that is literally the last gen drug we all know. So you never start it as an empirical therapy. Okay, meropenem should be given as empirical therapy. Okay, so this is for gram positive. Similarly, if you see for gram positive also, again amikacin sensitivity was good. Vancomycin sensitivity was almost 100%. Linezolid. So typical MRSA, we all give vancomycin as the empiric drug of choice. Signatures, do it for both days, madam. For both days, please do the signatures. You will see day 10 of ceftriaxone or day 8 of ceftriaxone still going on, which was supposed to be a part of prophylaxis. So that we can always self-evaluate. Self-revision can be done and stopped at the prescribed after the designated hours is over. Okay, and dosage optimization, education interventions. Yes. So what are these low-hanging fruits? Low-hanging fruits are nothing but they're easily that can be done very easily. Okay, so batching of IV microbials. Okay, that's not important here. So start me. So we'll go into this later. So resource driven. So yes, we have pharmacist driven intervention, stewardship nurses. So yes, PD we are not doing right now in our institute. And IT driven, yes, we have a good HIS system. And biomarker driven interventions. Biomarkers means we can always review if you're suspecting sepsis. You can wait for check with the biomarkers. Okay, that we have a checklist for that. I'll show you. And guideline based. Okay, this we are starting. So antibiotic policy guideline. In this only we are involving both empirical and surgical and antibiogram guideline. So most of this we are doing. Okay. So in this also in initiation bundle, what is the rationale? We just tick it yes or no. Rationale for initiation of the antibiotic. Appropriate specimens are sent before the initiation or not. Are we adhering to the local practice prescribing guidelines? And following hospital authorization guidelines and any other indwelling catheter, especially if it is from another hospital if the patient is coming, and any other interventions are there. And renal section unit clinician is doing it in the wrong way. We don't tell like that professional etiquette we have. Non-interference is usually what we try to opt out, right? And yes, local practices. And many institutions might sometimes do completely in a wrong way. They don't even know that. And yes, opinionated leaders, especially if they deliver wrong information. That's just pure chaos. And yes, this point is always there. Pharmaceuticals, medical reps, patients demand. Most of the patients don't like this wait and watch. They tell, just start it right now. Yes, right? They want magic. Expect doctors as magicians. They want immediate results. So wait and watch is usually patients don't like. Costlier drugs, costlier diagnostics. Patients like that's a very wrong notion we see. Like they feel like if you are giving a big test, sending the patient for a big test, yes, the doctor knows has a lot of knowledge, right? Most of you have might have encountered such patients in your private practice, right? And yes, prescribers anxiety. So yes, let's start it early. And yes, so anybody knows this monkey rule, 5 monkey rule experiment? Does anybody know this story? What is this 5 monkeys experiment? Okay. So they were a group of scientists placed 5 monkeys in a cage with a banana on the top of the ladder. So every time a monkey wanted to, obviously monkey wants to eat the banana, right? So whenever the monkeys went to take the banana, they used to shower cold water as a punishment. So after some time, no monkey tried to go take the banana. Now after a while, whenever this one monkey wanted to take the banana, other monkey started beating this monkey after a few days. So after this, the all in the 5 monkeys, they substituted one monkey with a new monkey. So this new to grab the when it started to climb the ladder to grab the banana, the other monkey started beating this monkey, irrespective of the cold shower. Okay, you're getting the point. That they didn't shower any cold water then. Just the minute the monkey went to start grabbing the banana, the other monkey started beating him. So eventually, all the monkeys were replaced by new monkeys. So one by one. So The first 5 monkeys that were there are completely replaced, and we have completely new monkeys. And whenever the new monkey was added, if the monkey tried to grab this banana, all the other monkeys started beating them. So if we ask the monkeys why they are doing it, the answer will be this: I don't know why. That's how we have always done things around here. So that is how many places it is. We don't know why we are doing. It's just hierarchy. We don't want to cross the lines. We don't want to hurt anybody, and we just do because it's always there in the past. So let's change that mindset and go into a growth mindset. So again, this is just for revision purpose only. Okay, this we all discussed: cycling, stop orders, so timeouts. Yes, this we all discussed in the previous slide only. Yes, and yeah, prescription audit can be done. Yes, smart, start smart. Okay. Okay, mind me strategy is very straightforward. So microbiologist gives the therapy. Indication should be evidence based. Narrowest spectrum should be taken. Dosage individualized to the patient, and minimize the duration wherever appropriate. And yes, IV to oral stop strategy should be incorporated when and wherever possible. Yes, low hanging fruits. So with this, we'll conclude our session. So cultures should be sent before starting the antimicrobials. IV to oral conversion should always be evaluated. Overlapping or redundant antimicrobials. So overlapping antimicrobials are like, can anybody give a good example? Meropenem and metronidazole. Both have anaerobic coverage. So you don't have to start metronidazole. But many times we see people giving both meropenem and metronidazole. So redundancy. So that reduce each other's effectivity. Okay. And yes, surgical prophylaxis should be, this will discuss one way, sir, and dosage optimization. Yes. Okay. Thank you. So I'm quite confident you all know how to read MICs, how to interpret. So let's not go into those details. Or shall we discuss a few pointers on that, or shall we move on to surgical prophylaxis? We'll move on. Yes, you want? So yes, okay. Next PPT pettara. Okay, we'll finish that in 5 minutes. Okay, so again, this is our gold standard guidelines. So whatever I'm saying is in accordance to these only. Okay. So stewardship we have already discussed. So MIC, MBC, we all know this. So sidal versus static. So which is much better, sidal or static? So the common misnomer is sidal is better. No, static drugs also can be, they also kill the organism. So if you prefer static is better for a situation, you can always go for a static. We all know that, right? Synergy. In endocarditis, synergistic drugs are more preferred. So my point is aminoglycosides, so gentamicin. So per se, aminoglycosides are intrinsically resistant to gram-positive organisms, all of them. Aminoglycosides work only in gram-negative, right? So should we give it or not? Many guidelines say that we give it. So what is your take? Should we give it or we not give it? We should not give it. It is there. It's in literature. It is SRs. Huh? If SRs, they will know. Just PG fresh passwords at the Chapanama. That is a question for you. Any SRs are here? Senior residents are here? That is a PG question, no? What is synergy? Significance of high level gentamicin ain't? Okay, see, it's not increasing the dose. It is nothing but it has synergy with the beta lactam agent. See, aminoglycosides, if you give it individually, it will never work on a gram positive organism. But if you give it with a beta lactam agent's mechanism is to break the cell wall. Okay, it's a sidal drug. Beta lactams act on the cell wall by breaking it. Various mechanisms are there, but simplest way is to, it breaks the cell wall. Okay, by binding to the various structures on the cell wall that are usually supposed to form the cell wall. So because they will not be formed, it will break it. So once the cell wall is broken, the aminoglycoside can enter. So that is why this combination therapy is very effective, even though there is no coverage. Once the cell wall is broken, the aminoglycoside can enter in. So that is nothing but synergy. So high level gentamicin is a misnomer, because it shows that just because it's high level doesn't mean high doses are required. It is synergy. Okay. Okay. So Sidal versus static. So yes, both of them kill the bugs. Yes, okay. So MBC and MIC, we know the basic differences, right? So minimum bactericidal concentration is just 1.L, 1000-fold reduction in the bacterial density at 24 hours. So this is something in vitro, where we record the CO2 temperature concentration, that is 5%, temperature 37 degrees, media, whatever media we are using, okay? But MIC is the drug concentration that inhibits the visible growth. Okay. So MBC is fourfold above the MIC, and for static, that's for Sidal. For static, it is eightfold. Okay. Just the dosage will increase. Okay. So this is 1000 for Sidal drugs. If 100-fold reduction of bacteria comes at a fourfold strength of MIC, just give me the number 1, 2, 3, 4, 5. Yes, yes, sir. 4 is right. So, see, because it is intermediate, okay, piperacillin and tazobactam and cefoperazone sulfactam. So, we will need their MIC values so that we can give an adjusted dose. We will increase the dose of the antibiotic. So, you can't just start pip but you will need a higher dose of pip right? See, piperacillin, tazobactam, especially CLSA defines the breakpoints as susceptible and dose dependent. In that case, you have to increase the dose of the drug, then only it will work. Okay. That too, what kind of antibiotic is pip Time dependent or concentration dependent? Beta lactams, meropenem ela istam manam? What is the standard treatment set in ICU patient is there? How will give meropenem as? Loading dose istama, stat istama, over time period istama? How is it given? Come on, you all know this. See, area under the curve, time dependent killing. Low, you will glycopeptides, linezolid are time dependent killing. So time dependent antibiotics, beta lactams. That is why we give it as 3-hour infusions, 6-hour infusion system, right? Are concentration dependent? We can give it stat. Aminoglycosides, best example, right? Okay, so this is all you know. This is pure pharmacology. And again, so hydrophilic, hydrolipophilic, main difference is their how they are metabolized. So if you know, so metabolism is like to see the check for toxicities. So renal toxicity ki hydrophilic agents, you will always keep an eye on them, right? So HLG we already discussed. And yes, finally, let's close with this. So yes, so especially if you see something as SDD, so no, please know that SDD means you have to increase the dosage. Okay. So susceptible either we will give for 1 gram over 12 hourly. For this is just examples. So SDD either you will give 1 gram 8 hourly or 2 gram 12 hourly. Into details. So, sir will cover them. Okay. Okay. So this all basics, you know, what we'll give if it's an ESBL, what we'll give if ceftazidime, avibactam, aztreonam produce chestamo. Okay. MBL producers lo aztreonam ante MBL producers lo aztreonam istam usually. Okay. Yes. And crab. So crab, this was what we were giving it AIMS. So this is our hospital institutional policy for crab, carbapenem resistant Acinetobacter we used to give a triple drug regimen therapy there. So we can change our own guidelines here, but this is a very standard guideline. They we did lot of meta-analysis studies, see review articles, see, and live patients history. The patient's recovery was better with the triple drug rather than the double drug therapy combination therapy. That we have concluded, they have said this meropenem, ampicillin or minocycline, and meropenem, ampicillin or polymyxin B. So ampicillin లో ampicillin component sulbactam component ఒకటే తీసుకుంటాం. However, meropenem resistance వచ్చింది అంటే if the MICs are greater than 8, change it to a polymyxin B. Okay. If only MICs are less than 8, we'll add meropenem. But sometimes, even if it was resistant also, the combination therapy worked. Okay. So this was there in that institute. We don't have any obligation to follow this also. Thank you. Yeah. So please give your suggestions. Please go through the policy once. We want to change it definitely. It is a very rough draft that has been prepared in the last minute. So kindly go through the policy. I'll post it once again along with the post test and feedback form. Please give your valuable suggestions to us. Thank you.
Start with a case. A 53 years old lady, known case of diabetic hypertension, was brought to casualty by relatives with complaints of fever, altered sensorium, and lower abdomen pain, and associated with burning duration of 3 days of duration. On examination, patient was drowsy, tachycardic, and hypotensive, tachypneic, and hypoxic. And examination of abdomen was soft and non-tender. And following examination, and X-ray was suggestive of bilateral non-homogeneous opacities, and CT-KB was suggestive of right-sided emphysematous pyelonephritis, and ABG was suggestive of metabolic acidosis and hypoxia. And from the history and what is our final diagnosis, whether it is a sepsis and the sepsis. In infection, there is no organ dysfunction. Sepsis is a organ dysfunction is present. But keep on emphasizing last 2 decades, this surviving sepsis guidelines, nothing much change, but everything emphasis on the do it early and identify the patient early, give the treatment early. And how do you diagnose organ dysfunction? Based on the SOFA score. And what is the definition of septic? Then patient increase the mortality, it will every 1 hour, it will increase the mortality by 10%. RCTs are done. So timing of antibiotics is very important. So all now antibiotic classes afternoon. Why this class very important or not? Why we are all called? Because of NIH purpose it is called. No. So why do I bother myself with all these rules? Can I initiate antimicrobials in all patients? I be safe? No. Why? Because indirect harm to the future patients, and it will increase the prevalence of multi-drug resistant organisms. By end of 2050 or 2040, it is one of the most leading cause of death in all hospitals. And toxicity to the host, it will cause the nephrotoxicity and hepatotoxicity and bone marrow toxicity. Again, it will increase the cost and give it to other consultations like nephrology and hepatology and hematology. And direct harm for infectious status, how it will happen? If unnecessary, inappropriate due to antibiotics, it will suppress our immunity. Again, it will cause the increased prevalence of multi-drug resistant. Now we decided about in this patient will give the antibiotics. We think, okay, this patient we will give antibiotics. So which antibiotics we will give? This is based on we have to know antimicrobial spectrum and penetration of the antibiotic, whether this antibiotic will penetrate that urinary genital system. This is the urosepsis. If some antibiotic will, whether we will give monotherapy or multitherapy, again, whether this antibiotic will cover MDR, MRSA, and fungal coverage. These 6 components we will keep in mind whenever prescribing antibiotic. So coming to the penetration of antibiotics, it is mainly depends on the lipid soluble and water soluble. Lipid soluble antibiotics, they have good tissue penetration, high volume of distribution, and low blood level, and useful in skin and soft tissue infection. And water soluble antibiotics, very poor tissue penetration and low volume of distribution and high blood level. So useful in bloodstream infections. These lipid solubles secreted in the bile, good in cholangitis. They need liver adjustment dose, especially in liver dysfunction patients. And water soluble, they secreted in urine, good in urinary tract infections, but they need renal adjustment based on creatinine clearance. So once penetration is over, we'll think about, does the antibiotic will cover the pathogen? So before our case, it is a uncontrolled diabetes, elderly lady, it come with urosepsis. Common organisms will be gram-negative organisms, community acquired. Again, whether it is a ESBL or coming slides, we will discuss. Just brief about what are the various classes of antibiotics. Usually cell wall synthesis inhibitors, these are all bactericidal drugs like beta-lactam group, we all know, glycopeptides, and cell membrane disruptors. Commonly is polymyxin, and protein synthesis inhibitors, these are all bacteriostatic drugs, some drugs are gentamicin. So not preferred in neutropenic patient, especially neutropenic patient will prefer bactericidal drugs only. And to optimize antibiotic combinations, better to give bactericidal combinations only. Why it is important? These bacteriostatic drugs stop the functions of the cells, and this might impair the killing effect of the bactericidal. So combination of cidal drugs is better. So try to avoid meropenem and linezolid combination. Linezolid is a bacteriostatic and meropenem is a bactericidal drug. And again, this understand the spectrum. It will miss the and atypicals. Usually cell wall synthesis inhibitors, these are all not effective in atypical organisms. What are the examples of atypical organisms? Except pulmonology, anyone can tell. They know, they will only treat regularly atypical organisms like chlamydia, mycoplasma, legionella. So they are not effective in atypical organisms which do not have the cell wall. That's why we should know the antibiotic classes, various classes of antibiotics. So we know common antibiotics, around 50% of antibiotics we will use the beta-lactam drugs. Common is penicillins, monobactams, cephalosporins, 5 generations, and carbapenems. And this beta-lactam, usually this beta-lactam can be broken by beta-lactamases. For that, extended spectrum beta-lactamase drugs they have discovered. Examples like clavulanic acid and ampicillin plus sulbactam. We will commonly use daily, day-to-day BLBLIs. Everyone will initially, my training period, I was surprised, what is BLBLI, all these things. This BLBLI means common day-to-day is piptas, piperacillin and tazobactam, and cefpoarizone and sulbactam, and newer novel beta-lactams. And beta-lactam, it is a extreme negative. That means extreme spectrum. Extreme positives are gram-positive cocci day-to-day are common gram-positive cocci, enterococci, and MSSA, streptococci. If these resistant and MRSA and VRSA, other than this, atypical organisms and anaerobes. So whenever prescribing antibiotic, we will keep in the mind whether we are covering these antimicrobials are very important. So for that, we need to know antimicrobial spectrum. So antimicrobial of limited coverage, which used in common infections, examples like perforation peritonitis, any biliary sepsis or appendicitis, and urosepsis. So usual organisms are here I highlighted: Proteus, spice group of organisms, anaerobes, and gram positive. So initial gram positive. So community respiratory infections, it will cover the atypicals. Atypicals will cover. So we have to know these macrolides and doxycycline, it will cover, both will cover atypicals and anaerobes. And third generation sequence, it will cover the initial narrow spectrum of both gram positive and gram negative. So any patient if come with community acquired non-resistant pathogens, what are antibiotic third generation cephalosporins like ceftriaxone or cefepime, ceftriaxone, or along with macrolides or doxycycline we will add. Antibiotic good coverage for community acquired non-resistant pathogens and anaerobes without atypicals, then clindamycin we can add with ceftriaxone. We can avoid doxycycline and macrolides. If antimicrobials have broad coverage which can be used in resistant infections, antibiotics it will cover the CRA organisms, MDR, Acinetobacter, and it will cover the MRSA and VRSA. So vancomycin has a broad coverage. It will cover the MRSA, anaerobes, enterococcus, MSSA. Like madam said before, if MSSA, again we will de-escalate to the MSSA organisms like cefazolin or cefuroxime. Usually we will give for MSSA organisms or fluoxacillin. These kind of antibiotics will be there for MSSA, but vancomycin also has MSSA activity. And linezolid, it will cover the VRSA and VRE. Vancomycin okay and vancomycin resistant staphylococcal RES, along with all other organisms, linezolid also it will cover. Cefepime is the fourth generation cephalosporin. It will cover the Pseudomonas aeruginosa, we have to know. And carbapenems has again broad spectrum coverage. MRSA cover even some gram positive and gram negative organisms also. And aminoglycosides, like madam said before, it is only cover gram negative organisms until up to ESBLs. Quinolones also, fluoroquinolines, that's why we keep it as a reserve drug. India in fluoroquinolines, especially levofloxacin and moxifloxacin, recent delafloxacin also came, but we will keep it as a reserve drug. India is an endemic country for TB, so better to avoid fluoroquinolones in India, especially like a reserve drug. If any patient landed up in drug-induced hepatotoxicity based on ATT, we can give only fluoroquinolone only option. If you before use the fluoroquinolone in that patient, if he had drug resistant, and it is very difficult to treat in TB. And fluoroquinolones he will has the more exposure of drug resistant organisms based on hmm. మైక్ లేదా మేడంకి సార్ కరెక్ట్ మ్యామ్ 2014.
So static drugs do kill the organism. It's not like they don't kill the bacteria. Always prefer a static drug if you think that that has a lesser side effect. So in that, the example you quoted was for meropenem and linezolid. So yes, that kind of exemptions are there, and yes, definitely atypical bacteria is a very good exemption. Static drug, if in both of them you feel the distribution and toxicity is less for the static drug rather than sidal drug. So this was in the past, like 15 years or a decade back. Sidal drugs definitely more superior ane oka ivi unde. Yes, that was there, but yes, we can give static drugs also.
Yes.
But yes, exception definitely there.
Static drugs we can use like madam said, but better to avoid combination of sidal and static drugs. We can use only static drugs and sidal drugs separately, but if no other option, we have to give static and sidal drugs. These are all better combination like beta-lactam plus aminoglycosides and beta-lactam plus beta-lactamase inhibitors, beta-lactam plus macrolide, and if patient has a necrotizing fasciitis, we will add clindamycin. So next thing, when we're starting patient with antibiotic, so we decided penetration and we know the antimicrobial spectrum, we know the right combinations, what combination of drugs we will give. Now we have to give only community acquired infections or hospital acquired infection, whether this patient has MDR, MRSA cover or fungal cover is also thing. How we will think before, as I said before, we have to think for risk factors in this patient has MDR organism risk factors, MRSA risk factors are present or not. We have to think if it is present, then we have to add. So before that, we all talk about resistance. These are the major 4 mechanisms of the antibiotic resistance. One is by drug efflux, expelling the antibiotic, and inactivation of enzymes. By common beta-lactamases, it will inactivate with enzymes, and changing the target protein. That means penicillin binding proteins, it will change the target, and membrane permeability. There are porin channels. It will change membrane permeability. Will 4 mechanisms in antimicrobial organisms will acquire by various routes. Uma, slider is not working. Battery is over. అరే మీద నిన్న బాగానే పని చేస్తున్నాను. Battery is just Uma, it is working. Stay there if you want to will come. So in before slide, madam already discussed amber classification. Important, we have to know various beta lactamases. It is a 4 classes: class A, class B, class C, and class D. It is based on various target enzyme, serine target side and metallo narrow spectrum. It will deactivate the narrow spectrum penicillins and narrow spectrum cephalosporins. Examples like TEM1 and TEM2. These enzymes will diagnosed by molecular diagnostics. Now rapid molecular diagnostics are available for various syndromes. For pneumonia, it is a pneumonia panel. For a meningitis, it is a meningitis biofire panel. In that also we will identify these enzymes. Based on that, immediately we will change the empirical therapy. Even for blood, it is a blood biofire. Even GI infection, again GA/4, different organisms we can identify. For extended spectrum beta-lactamases and affect the narrow and extended spectrum beta-lactams, then piperacillin and tazobactam, ceftazidime, sulbactam. Common is CTXM genes and serine carbapenemases. These will affect the carbapenems. And KPC1, it is usual common in Western countries. In India, what is the common carbapenemases? OXA48 and NDM. OXA enzymes and NDM is class B. It is a metallo-beta-lactamases. Most beta-lactam, including carbapenems also, it will destroy. So in this patients, in this group of patients, if you give carbapenems, and these will not work. It is low. And class C, again, cephalosporinosis. Most common here important is AMP-C organism. Some spice group of organisms, if these spice group of organisms already expose the cephalosporins, they will express the AMP-C enzymes. Once these enzymes, they will destroy the cephalosporin. Even though culture and sensitivity report, for example, madam before showed Proteus or Pseudomonas, it is sensitive to certain peptides or cephalosporin sulbactam, but it will destroy by AMP-C. So we have to start with only carbapenems only, spice group of organisms. And OXA type A enzymes, penicillin, oxacillin, and carbapenems. These enzymes we will keep in mind. Even this will help in molecular diagnostics. In India, common is nowadays most common thing are OXA48 and NDM. Combination is most common. Coming to our recommendations. So for adult with septic shock, if these patients have a high risk for MRSA, they recommended using empirical antimicrobials with MRSA coverage. We already know what are all antibiotics it will cover MRSA. If it has low risk for MRSA, then they suggested against empirical antimicrobial using with MRSA. Again, with gram-negative organism, if patient has very high risk for MDR organisms, they suggested using 2 antimicrobials with gram-negative coverage, like peptides along with aminoglycoside, peptides. So 2 gram-negative we have to coverage for a high risk of MDR. If patient has no high risk of MDR, only 1 gram-negative coverage is enough. But once culture report came positive, we have to change to the targeted therapy. This is only empirical therapy. Once culture report will come, we have to give only 1 gram-negative agent. Even for fungal infection also, if patient has a high risk factors for fungal infection, they suggested using empirical antifungal therapy from initial words. If low risk of fungal infection, they suggested against use. What are common fungal risk factors? Very admission, very high Apache score, very broad spectrum antibiotics for a longer time, patient on total parenteral nutrition, and major intra-abdominal surgery. And these are all very high risk factors for fungal infections. So these are different source of infections. One patient with skin and soft tissue infections or intra-abdominal sepsis like perforation peritonitis or community acquired pneumonia or in hospital associated pneumonia or ventilator associated pneumonia. Another thing is post sepsis. So what is the appropriate empirical antimicrobial for each patient? Can anyone answer one by one? What is the common antibiotics for cellulitis or community acquired pneumonia? That's all before what we discussed here. For patient A, so whenever prescribing antibiotics, once we decided, okay, we will give antibiotics this patient, then we will thinking, so what organisms we are covering with these organisms? Usual skin and soft tissue infections, it will cover commonly gram-positive organisms, staph and strepto. But with risk factors for MRSA, then we have covered with vancomycin and linezolid. Or if it is a necrotizing fasciitis, is it clindamycin, it will treat the toxins. Nowadays, only clindamycin rarely used, but only usage is in the necrotizing fasciitis, along with vancomycin, clindamycin. If these patient risk factors for Pseudomonas aeruginosa, then we will add peptides. Commonly, we will use what antibiotic, either peptides or ceftazidime, sulbactam, along with clindamycin, we will use. If risk factors for MRSA coverage also, we will start. Once starting cultures and septic biomarkers. This perforation peritonitis, usually intra-abdominal organisms are usually gram-negative. Gram-positive, here it is a enterococci. Mostly we'll forget vancomycin will cover MRSA. So enterococcus also we'll keep in mind. So that also will cover the vancomycin. So they recommended broad-spectrum beta-lactamase along with metronidazole, enterobic. If directly has a risk factors for MDR, if we start meropenem, no need to cover metronidazole here. So directly, if patient has no risk factors for MDR, Pseudomonas, and MRSA, no need to give. Simple broad, as we all know, common pathogens will be gram-positive, staph, strepto, and Haemophilus influenzae, along with atypicals. usually American Thoracic Society or American. This is where it is very, very, very important. Madam already presented our hospital. What are the common organisms? Gram negatives like E. coli, Klebsiella, that is already CREs. Then MRSA also, incidence also very high. Hospital acquired pneumonia, better to will start with like a MRSA coverage and extended beta lactam. Here fluoroquinolin we can add. Fluoroquinolin, it will cover the extended spectrum also. But in our hospital, CRE is more high. If CRE means like in metropolitan cities, they will start directly with a ceftazidime plus avibactam and azotenum or tigecycline plus. Directly they will start. Once cultures will come, they will de-escalate. Because in India, CREs are more going up towards. That's why at 2040, 2050, this is the leading cause of deaths, MDR organisms. So we will minimize the antibiotic resistance. So what is the dose? Once we decided about antibiotics and we have selected the appropriate drug, then we have decided about dose. Whether dose will give bolus dose or infusion dose or loading or not, these are based on the pharmacokinetics and pharmacodynamics principles. They recommended prolonged infusion of beta lactam for maintenance surviving sepsis. Why they recommended? This is the rationale behind. Madam already told there is a certain categories of antibiotic based on time dependent killing and concentration dependent killing, and AUC by MAC, it is a time dependent along with some concentration dependent post antibiotic effect. So why should we give a loading dose in some drugs, and should the loading dose of antimicrobial suggested in AKI? So many residents, patient already on CKD, end-stage renal disease or AKI, whether we'll give loading dose or not. In coming slide we'll see. So loading dose, it is dependent on the required serum concentration along with volume of distribution. So neither the required serum concentration and volume of distribution is affected by kidney function. So loading dose is not adjusted in patients with renal function. So next dose is we have to give based on the renal function. So loading dose, antimicrobial adjusted in AKI, no. Illness and antimicrobial relationship. What happens in critical illness? Critical ill patients are completely different. That's why in 2014 in India, they started the critical care medicine courses. So their group of patients completely different. Their pharmacokinetics dynamics are different. So in these patients, what happens? They will increase the tissue distribution of antibiotics, and here also augmented renal clearance will happen. So if you're interested, you will go through this research published in an intensive care medicine journal, antibiotics in critical ill patients and a systemic review of pharmacokinetics of beta lactams. So what is the solution for these problems? So they need increase the loading dose in critically ill patients, especially with water-soluble drugs, and therapeutic drug monitoring whenever possible. Now, metropolitan cities, vancomycin, if you are prescribing, therapeutic drug monitoring is the standard of care. We need to monitor vancomycin therapeutic drug level. Because why? Whoever patients on vancomycin, lot of RCT and systematic reviews, it is mostly they concluded that suboptimal doses of vancomycin only they given. So vancomycin and aminoglycosides, we have to do therapeutic drug monitoring whenever is possible. It is a standard of care nowadays. So these are pharmacokinetic variability of beta lactams in critically ill patients, majorly based on high variable of volume of distribution. Their pharmacokinetics and dynamics entirely different and highly variable clearance. And they concluded because of large pharmacokinetic variability of beta lactams, they need standard dosing regimen can often be suboptimal. So that's why therapeutic drug monitoring appears as the best approach to guiding doses. Otherwise, treatment failures will happen. So once we decided about drug and what is the dose, then finally de-escalation and duration. What is important? So what is the de-escalation? Whether we'll decrease the higher class to lower class of antibiotics, or we'll stop the antibiotics, or duration. How much duration we'll continue once we'll start. Surviving sepsis, they recommended we will daily assess the antibiotics, whether this antibiotic will stop or not. It is very important. So biomarkers in initiation, biomarkers is important. What are biomarkers in sepsis? C-reactive protein and procalcitonin commonly we'll use, but usually it is not. They suggested against the using procalcitonin plus clinical evaluation to decide when to start the antimicrobials to compare to clinical evaluation before. Like our case before, patient already has a sepsis based on presentation, patient history and examination and laboratory values and radiological values. That is enough to start the antibiotics. no need the biomarkers. Then why it is biomarkers is important? Doxy, these all 6 antibiotics will add. So as early as possible, we will do the LP and get the LP CSF analysis report immediately. If no meningitis, immediately stop the antibiotics. That's how we will do. If these antibiotics will go for 5 days, 7 days, and those patients will landed up in again multi-drug resistant infections. Even for empirical MRSA coverage, if you add, then like source of sepsis, like in a surgery, simple gram stain, even sputum produce, it is a gram negative, gram positive, we can stop the gram positive organisms. Like certain rapid diagnostic tests, it will helpful for de-escalation of empirical antibiotic regimen. And use of antibiotic resistant prediction tools. These are Western countries, how we before discussed, like procalcitonin based guidance of antimicrobial therapy and formalized antimicrobial stewardship program. That's why these NABH and quality control boards of India, and they are keep on emphasizing formalized antimicrobial stewardship program and rapid microbiological diagnostics. Like nowadays, all PCR based or rapid diagnostic tests are available. Like what way ambler classification certain enzymes we discussed, those enzymes we can detect and we can optimize the antibiotics. And if very resource limiting certain patients in villages, they can always pursue telemedicine driven stewardship or telemedicine based consultation. ID physician, we can take consultation. Our closed multidisciplinary ICU, it is a multidisciplinary team. 3 or 4 consultants will come. They will write different antibiotics and discuss all together, and we'll keep it as a one line. And optimized infection control program to minimize these all recurrent infections. We have no need specified optimal infection control program. So when daily checklist, daily we have to think whenever any antibiotic is going on patient. And I will conclude. Thank you. So we have to wait another 10 minutes session. I will finish. So Kalyani, Dr. Kalyani, emergency medicine assistant professor, she is supposed to take this class. She is not well. So from our quality department, they given writing of medical records. So whenever we'll keep ensure our residents to make sure we'll write these medical records. Uma,